Good afternoon and good morning to those of you from other parts of the country. My name is Patty Hyde and I am the Director of Clinical and Regulatory Affairs for the Home Care Association of Florida. And I'd like to thank you for joining us today for this event that is being offered in partnership with the Home Care Associations from the states of Arizona, Nebraska, and Massachusetts. Before we get started, we'll go through the usual housekeeping items. So first off, we will be recording today's event. If you'd like to recommend this program to one of your colleagues, we always appreciate that. And it will be available for purchase in the near future through the association you registered through, and also on our e-learning website at www.homecarelearn.com. Handouts were contained in the login instruction email you received from your association, but in case you cannot locate those handouts, just know that you can download them now from the GoToWebinar console located under the heading Handouts. Participant phone lines have been muted and will continue to be muted during today's presentation to help minimize background noise. However, for those of you who are listening in through the phone line only and you are not also logged in online, we ask that you please mute your phone using your phone's muting feature. So please help us avoid any disruptions during the presentation by taking a moment to mute those phones now. Time has been scheduled to allow for questions at the end of today's session. So please type your questions as you think of them so you have enough time to get them in. And you want to include those questions in the question box area of your GoToMeeting console. If you don't see this area on your screen, you want to look for the feature from the menu that's at the top of your screen. You want to look for the orange box with the white arrow, which will expand and collapse the console. We'll be able to see the questions and we will compile them throughout the presentation. We'll read them aloud for our presenter to respond to them verbally for everyone's benefit once we open the session for questions and answers. And with those announcements out of the way, I'm going to go ahead and start our recording. And now I would like to officially welcome you to today's presentation on value-based purchasing score improvement. And this is our 6th and final installment of this series, which will focus on drug education and vaccines. And it's my pleasure to introduce today's speaker. Sharon Litwin has been in the home care and hospice industry for over 30 years. Prior to founding 5-Star Consultants, she was Executive Director of the Home Care and Hospice Services Division for Unity Health in St. Louis, Missouri. Sharon was an ACHC surveyor until December of 2013 and also a former CHAP surveyor performing Medicare deemed surveys for 10 years. In her consulting firm, she and the 25 RNs who make up 5-Star Consultants assist agencies in providing quality, meeting regulations, managing efficiently, and achieving financial viability. Sharon and her staff perform coding and OASIS reviews, clinical record reviews, mock surveys, and help agencies across the country stay in compliance. Sharon regularly speaks at national and state associations and does frequent webinars for education firms on many topics such as continued survey readiness, ICD-10, case management, OASIS assessments and diagnosis coding, management and operational topics, QAPI, as well as various other topics integral to being successful in the home care and hospice industries. So with that, Sharon, I extend a warm welcome to you and turn things over to you.
Thanks, Patty. Wow, what an intro. I think I need to give you a shorter version. It's embarrassing sitting there listening that long. Hi, everybody, and welcome to part 6 of our value-based purchasing. Before we get started, I want a little disclaimer here and tell you that my allergies are very bad today, so please bear with me if I do have to stop to cough. What we're talking about today is like Patty said, the drug education of all meds. That's a little bit different than the improving oral meds that we did last week, but a lot of the focus is on those same things that you learned last week, so we will build off of that. And then the flu and the pneumococcal vaccines. So as we look at what is on the outcome reports on CASPR now, these 3 are all in the process measures, if you remember the PVQI, and that's process-based quality improvement. We know them more as process measures. The drug education for all meds, that's of course in 2016, and that is at 97%. The flu immunization is 1046, it's 76%, and pneumococcal 1051 is 79%. So you see right there, obviously, you need to be way in the top box for drug education for all meds because that's so high. And if you are hanging right around the national for the vaccines, that's good. You want to be at national or over, of course, but you can see that there's a way to go there because that's something that we don't have a lot of control over. And if you remember correctly, in this year's final rule, 4 measures were removed, the prior functioning ABL and the last one, care management types and sources of assistance. But the other 2 were the flu vaccine data collection period and the reason the pneumococcal vaccine wasn't received. It was good they removed those because there's absolutely nothing that you can do to improve those. They just are what they are. All right, so we'll start with M216. Patient caregiver drug education intervention. So what it is at the time of or at any time since the most recent start of care ROC assessment. That was a newly revised one from January's OASIS C2 because they don't include the research since that doesn't get counted for the outcome. Was the patient caregiver instructed by agency staff or other healthcare provider to monitor the effectiveness of drug therapy, adverse drug reactions, and significant side effects, and how and when to report problems that may occur? Now, I know that clinicians tend to rush through this, but when you're looking at doing this at discharge and saying that every time there were any issues with meds and the patient and family knew all about it and you dealt with it and then you documented, you reported it if necessary. This is a very meaty item. Pardon me. The national is at 97%. The challenge that I see with this item is, of course, you want to be at 98% or 99%, particularly with the value-based purchasing pilot, yet alone star ratings. But you can just put a yes to it, absolutely. But there's no OASIS integrity then. So often, both as a surveyor and a mock surveyor, I'm out there and I see, clients report all the time, even if we didn't do the mock survey, and medications is a deficiency. There are challenges with medications all throughout the episode of care. It's very hard to manage medications and to improve a patient's welfare with their medications, whether it's with the med outcomes or, as an example, if it's with pain. I gave this as an example last week, but what if the pain meds that the patient's taking isn't relieving the pain? Well, in the course of that episode of care, did then you find out if they're taking it as it's prescribed? Did you see, okay, it's not effective? Did you notify the physician? And did you get an increased med dosage, as an example? This is what we have to do all throughout the course of the episode. And I think all of you realize that this is a challenge in home care. It always comes back to the patient's team, the case management team, where I'm the nurse, Bob's the PT, Sally's the OT, as an example, and the PTA working with Bob sees that the pain's not effective. And so that has to be carried up to the PT and maybe to the nurse to call the physician. That all has to be documented. If that hasn't been done, then by the literal meaning of what this OASIS item is, you cannot check yes for this. And so that's the problem with this outcome. You don't want to just tell your staff, or as a clinician thinks, well, of course we do this, and just checks it back, because as you look back, is there integrity with your answer? These are called, even by CMS, look-back items. And they are meant to have the discharge clinician, who won't know about every visit and every time that patient, every day that patient went through, do they look somewhere to find out if this has occurred? Well, obviously, you're not going to read every visit note. You're not going to read every order when you're doing a discharge oasis. So what do you have to do? Well, the agency has to have a process where and how this documentation is located so that the discharge clinician can easily go to one point of contact and see what the medication situation is all during the course of care. So this is very important for you to set up. If you're on EMR, as most are, then most EMRs have areas where you can do just that. And if they don't, you can be creative with where you put it in your EMR, where you put it in one place so that I can, as I'm discharging Mrs. Jones, look in, let's say there's a note section. They all call them something different. And some look like email, some are right in the body of the assessment. But where do I go that I can tell Bob and Sally each time something occurs with the medication? Now, when I'm already out and Bob discharges or Sally discharges the patient, they know to go to that notes section where we have it classified as drug intervention or drug education. And then you can see that, yes, this was done, no, it wasn't. So that's how this is meant to be handled. It's not just meant to be checked, yes. Whenever there is a med change, wherever there is any kind of an issue, such as the ineffective actions that I talked about, noncompliance is huge. A lot of times noncompliance isn't documented and considered when we're looking at the meds, whether it's in any of the med items. But noncompliance, you need to document why, such as they just don't think it's important, their education. They don't have the money. Well, those two things we can improve, we can take care of. So every time you see non-compliance, you are to notify the physician. Now, of course, if the physician at that point says, okay, I know he's not compliant, I'll see him in 3 weeks, well, then you document just that. But as non-compliance occurs again and there's no resolution from the physician, you need to notify them and you have to put it in the documentation. Anytime a patient has side effects, document it in this note section so that that is easily seen. And then duplicate drug therapy, any over-the-counters or if there's multiple physicians. So there are many reasons why you should be documenting in this section. The integrity is important. I mean, just because it's the truth, right? This is a legal document. If you're putting yes to something where issues were not addressed, and now I'm going to read, you have those 4 examples that I gave in the notes section from when they occurred. But now I'm reading the note somewhere along the way, and there is some discrepancy in the meds, the drug interventions, education, and I see that it wasn't reported to the physician. It didn't get moved up the line, as I described, from the PTA to the physician and whoever is in between. Well, then you're really supposed to put a no. And where this gets affected is when you have audits, particularly ZPIC audits, where that's the type of thing that they look for. So you want to make sure there's integrity. This is a legal record. All right. So now you want to identify if you're, this is from the item intent, which is from Chapter 3 of the OASIS manual that I talk about always, that you've heard about before and know how to get to that. Very important. It tells you what they expect us to do regarding each of the M items or GG items. Identify if clinicians instructed the patient caregiver about how to manage all medications effectively and safely within the time period under consideration. This item is used to calculate process measures to capture the agency's use of best practices following the completion of the comprehensive assessment. And of course, we do it at transfer and discharge. All right. So now the specific instructions that they give in the OASIS manual. Drug education interventions for M 2016 should address all meds the patient is taking, prescribed or over the counter by any route. Effective, safe management of medications includes knowledge of effectiveness, potential side effects and drug reactions, and when to contact the appropriate care provider. If the interventions are not completed, and that means for that whole episode, as outlined in this item, enter response 0, which is no. However, in this case, the caregiver should provide, not the caregiver, the care provider should document rationale in the clinical record. Well, you can see that's kind of difficult to do. If you put a no, you have to document why you haven't done these drug interventions. But remember, if you go and look at the chart and see that the physician wasn't called about meds on times when they should have been, then that should be a no. So you want to be sure, the biggest part of this is to find a place where the discharge clinician can look to see if this was done. Now, you're always missing if there were omissions, and that's just something your clinical record review is going to have to pick up on. Because let's say it was the example I gave you, there are 5 notes that the discharge clinician looks at that says, oh, good, meds were handled and documented, now I can put a yes. But what if there were 3 other times in the visit notes on that course of care that this wasn't the case? So that's where you will pick it up on clinical record review. You definitely want to be able to find these things prior to discharge so that they end up in the notes section, and you can correct them rather than a discharge audit where you can find out what you did wrong, but you can't correct it. So you are to look at, this is what the look back is supposed to be, is that you are looking at the review of the clinical record, including teaching guidelines, flow sheets, clinical notes, med list, plan of care, discussions with other agency staff responsible for educating the patient and caregivers on meds. And so if you really look at it, their look back item would mean that the discharge clinician is doing a full chart review. Now, we know that is not occurring because it's not feasible. Somebody is doing the full discharge review, hopefully in your agency, to see that. However, will it be in time for this answer? So this is important just to make sure that your clinicians know that they can't just automatically put a yes so that you guys get to 100% if that documentation and the interventions did not support it. There are links for other resources on drug education in Chapter 5 of the OASIS manual if you want to get more information from the manual. One assessing clinician I thought I would bring up here, because that is always so important, that OASIS has always been that it has to be the one assessing clinician. It's frustrating to me that in this year, particularly with changing our COPs to a case management approach or interdisciplinary team approach, that they still kept the one assessing clinician in OASIS, because it should be a collaboration, but they've stuck firm. Now, there are exceptions, and this is one of the exceptions. A clinician other than the assessing clinician may provide drug education in person or by phone to the patient and caregiver. If the assessing clinician at transfer discharge has knowledge this has been done, he or she may take credit with a yes response. So you're saying that you are collaborating, and that's why that note section is so important, because the other interdisciplinary team members are letting you know that, yes, we took care of this, so I'm a yes. Now check the others. If the assessing clinician evaluated the patient's retention of prior teachings, determined and documented that the patient possessed all required knowledge related to meds, then this would be yes at transfer discharge. And I apologize, that should be updated to 2016. All right, so how can we improve medication? Well, you need to, and like I said, this crosses the line to many other M items as we try to improve our outcomes on medications. This one and improving oral drug medications just happen to be the ones that are in value-based purchasing. But by doing this, you're going to be improving all of your meds. When all of your meds improve for the patient, then very often your pain and other symptoms of diagnoses improve as well. So you're increasing the patient's outcome. So you request the patient to gather all their drugs, prescription and OTCs at start of care. This allows assessment of the patient's physical ability and safety to get meds. It also gives you their cognitive state. It also tells you their vision. It tells you so many things. It right there can tell you if the meds are ineffective or not as you're talking to the patient about their meds. Hopefully, you are teaching high-risk meds at start of care and rock visits. So let's say there's 20 meds on the patient's med list. Well, only 2 of those were high-risk meds. Maybe we taught the other 2 on the start of care as well. Now, the other team members need to know, well, we haven't even looked at these. That's what the rest of the episode is for. So now we're going to get into every med specifically. Remember that your med education documentation has to be specific. We are very weak as an industry in documenting our teaching in very specific, in a very specific manner as it is to be. So, for instance, you can literally be denied a clinical record for a period they requested as an auditor because they're saying you had no skilled needs. Well, why would they say that? Those 20 meds, we had an awful lot to do with those, and they led to other interventions and improvements. But your teaching every time just says instructed patient and caregiver on their medication regime, or not even that much. They acknowledge that they understand. Or pick one med, the team doesn't talk to each other. I instructed on the patient's increased dose of Lasix. Now for the next 5 visits, I'm documenting about that Lasix. So those are things that occur frequently that don't even show skilled need, yet alone how we're going to improve medications. A lot of times medication crosses over with CAPS, and I know Melinda talked to you a lot about CAPS. But this is one I very often see cross over, that when we're working with clients, we see that their medication outcomes are not great, and that also their CAPS scores from the patients are not great on, did we teach meds in a way that the patient can understand, etc. So that means that you're doing a lot with meds, but you're not going to improve them because you're not getting through to the patient. You need to take a different approach. So use those outcomes for past patients to learn how to interact with the current patient. Obviously, you need to assess if the patient knows what each drug is for and when to report any issues to you or to the physician. Of course, issues that they tell you most often do need to go to the physician. And then, like I said, you want to document by name each of the meds you're teaching. And that goes especially for the high-risk meds. Don't just say high-risk meds taught. What are they? Is it Coumadin and insulin? Then document that specifically. If the med planner is present, check that it's accurately filled for the time meds are due. That's a big piece to be able to be on the right starting track. A lot of times that's where you will find med errors, is to see that they are taking, 2 pills of this a day when they're only ordered to have 1. Always compare your medications that you see on the discharge med list from, the SNF or from the acute care facility, or get a med list from the physician's office. And now compare with what you find in the home. This is really going to help you to find if there are duplicate drugs, if there are medication interactions, if there are a ton of OTCs, herbs and vitamins and minerals that the patient's taking that the physician has no idea about and is not good for their disease process or interacts with their prescription drugs. And probably most importantly, oftentimes that can really do harm to a patient is that they have multiple physicians ordering multiple different meds that their PCP, which is probably now your 485 signing doc, needs to know about. So it's very important to set that stage at start of care and rock. Have every discipline that's in there. Ask if there's any med changes at each visit and document if there are any changes. That is the best way to be sure that you are having integrity with your answers and the M items, and it's also the best way to improve your patients' outcomes so that they get better. So have your whole interdisciplinary team. You can include the aide as well, because the aide's just going to say, did you take your pain pills today because you're having a lot of pain? And they say no, well, then that's time for that aide to report that to the appropriate team member. So if you really educate all of your clinicians and aides that they're going to ask about med changes at each visit and say what changed, what is it for, are there any side effects, is it effective? Now, you probably have a case manager. That's an RN if it's multidisciplinary. And so you want to make sure that that case manager, who's just kind of tying the whole team together, knows about it, and we're absolutely sure that the physician's been notified and that it's documented. If medication education is documented as needed, requested by the physician, or reflected in M2102C, that's where you would check too for med education needed. Then you have to ensure the ability to take meds on M2020 and M2030 show the need for education. So this is the consistency throughout the OASIS. You can't focus just on this one M item for improving and not focus on the rest, because if you're putting a yes for this because you're in value-based purchasing pilot, and you put a yes to improving oral meds just because you're in the value-based purchasing product, but the M2102C, the M2020, the M2030, the pain M item, and so on and so forth don't match with that, that is then not appropriate. There is not consistency and integrity, and that's what auditors look for. If you, the clinician, make changes on the start of care visit to improve the patient's medication, don't count what you did. That way, you're scoring what the patient was like when you walked into the home. Now, you do an intervention that improves it. That's going to show improvement for the next time point. A lot of clinicians do things on the start of care visit and score accounting into what their interventions were. And so you're really hurting yourself in that manner. Okay, so the teaching focus is on effective, safe management of medications. There's no expectation that the patient caregiver has to be made knowledgeable of details such as the pharmacology, of course. You know that. So if you just hand them a drug paper education that has everything as if it's from a PDR, and then you don't know why in their cap they're saying you're not explaining it to them right, that would be why. And sometimes that's what's happening out there. Pages and pages of stuff that the patients and caregivers will never be able to understand or read is put out there in the patient's home. You want to make sure it's real for the patient. Does the patient caregiver understand the purpose of the med? Okay, so this one's for blood pressure. Are they aware of potential problems such as drug interactions, reactions, side effects to look for, and then list those side effects? Do they understand special precautions such as take your pulse before you take your evening dose? Do they know when and how to get help if problems do occur? That is going to you unless it's an emergency. They come to you. Now, one of the worst things that we see when we look at clinical records in home care is that they come to you or you identify something in the home. Let's say I find something in the home that this med, we'll just use an easy one, that this med is not effective for the patient's pain. They're only on Tylenol. They need to have something else unless there's a rationale that the physician doesn't want to order it. But let's say that's what you find. You are talking to the patient and his wife, and the wife says, we're going to go to the doctor in 3 days, so we'll let him know about that. And you say, great. You document in your notes that the patient's on Tylenol, they have a pain of 8. They're going to tell their doctor at the next visit in 3 days. That is very, very common in home care. And that basically is not acceptable because you are there to take care of that patient. You have to see there's an effective med, and great, you tell the wife says they're going in 3 days to the doctor, but you say, well, in the meantime, I'm going to give them a call now and let them know maybe you can get some meds prior to your visit. Then you can tell him and me how it's working. Very important thing you need to educate all clinicians on because that's very common. If they get meds from other physicians, they need to report it to you right away so that you can tell your 485 signing physician. I always like to call it that so you know exactly which doc I'm talking about. All right. So there is so much on meds, but I've talked a lot about meds last week on improving oral medications, and I talked about meds even with rehospitalizations and emergent care that I did in the first session, because so often that is from medications as well. So having a quality indicator on medication management is very important. And then that hits all of these areas, and you will really see an improvement in all of your outcomes on CASPR, and then specifically on your value-based purchasing pilot and your star ratings. You'll see an improvement once you dig in and do a quality indicator on med management, where you're hitting a lot of different aspects of care with med management, and you have a task force that's really working on it. I've seen lots and lots of agencies improve their CAP scores greatly and their item outcomes on CASPR by doing a quality indicator on med management. So that's what you really want to think of doing, particularly because you're in this pilot. You'll help a lot of your outcomes improve. Now, I was saying to Patty right before we started that there's really not too much you can say about the flu and pneumococcal vaccines. but I'm putting in the intent and the guidance, and then I have some other information that I put in here that will hopefully help you get to 80% on these, which would be then above the national average. So 1046, the influenza vaccine received. Did the patient receive the influenza vaccine for this year's flu vaccine? Of course, we, the CDC, CMS, everybody wants this to be 100% yes. So that's what we're striving for. So you in home care have to do the biggest part to be able to have that happen. There are many agencies that I see that say, no, we don't give flu shots. We don't want to mess with the med refrigerator and checking the temperatures and the 30-day expirations. So we just tell them to go to the Walgreens down the street or to get them at their physician's office. Okay, so what's wrong with that picture? We're not mandated to get flu vaccines, but are you doing the full holistic approach to prevent illness and improve outcomes in your patient if you say that? No, you are able to give flu vaccines. And if you're going in the home, why not give them? That is going to be a huge percentage. And I know there is a lot of agencies out there that have stopped giving them. However, it's not the best idea, especially if you want to improve your outcomes. So did they receive it? Did the patient receive the influenza vaccine for this year's flu season? Now, it can be yes from your agency during this episode of care, yes, your agency from a prior episode of care, already received from another healthcare provider, offered and declined. Now, if it's offered and declined, you really want to document your education regarding the flu vaccine and how bad the flu can be, and determine why they're declining it, and dig into it and see if you are able to change their mind. Then you would also, as a report to the physician after your admission, after giving them everything else, you'll just want to take a note, and whether it's in documentation or on phone or on fax, just put that we tried to get them to take the flu vaccine and they declined it. So that may be something that they can give or talk them into. The patient is assessed and determined to have medical contraindications. There aren't too many for the flu vaccine, so that should be a low number. 6, not indicated. The patient does not meet age and condition guidelines for influenza vaccine. Again, that's a small number. Inability to obtain vaccine due to declared shortage. Well, that should only happen in the years where it really is a shortage and you have checked all around to see if you can get it. Your pharmacies, your county health department says, no, we can't. Other than that, that's not a good answer. And then patient did not receive the vaccine due to other than those listed. So that's where you would have to document what those reasons are. It's hard to think of a legitimate one that would be in as other. For a patient, this is from the OASIS manual as well. For a patient with any part of the home care episode and then occurring, identifies whether it was given. So this is where we don't have to worry so much about identifying the dates anymore. This is for did you give it or not for the value-based purchasing. But yes, you would put 1 in 1041 if they received it during those dates. Like I had told you at the beginning, luckily that's being removed from the value-based purchasing. And then if you gave it during the episode, if you gave it prior to the episode. Now, on response 2, a lot of the clinicians don't know that you can enter response 2 if a patient was given a flu vaccine by your agency during a previous roster billing situation during this year's flu season. What that means is that you did a senior center and you gave flu vaccines all day to the senior center. Now you admitted Mrs. Jones and she got it from you that day. You can put yes. Now, if ABC Home Care did it at the senior center and that's where she got it, then you can't count that. But if you did it, that is put in as a billing roster, which is a list of all the names you gave patients to, and your agency submits that, so then you can take credit for that. Response 3, if the patient or caregiver reports that they got it from another provider. And then response 1, 2, or 3 entered if the flu vaccine was provided prior to October. Some years it's made early, it's made earlier. And response 4, if the patient or healthcare proxy, now that would be somebody that's their legal representative, refused the vaccine. And again, see why and try to, convince them otherwise. It's not required that the agency offered the vaccine. Enter response 4 only if the patient was offered the vaccine and he or she refused. So note, the OASIS manual isn't requiring us to offer it yet, but keep in mind what I told you. So the indications are listed here, and that is anaphylactic hypersensitivity to eggs or other components. I've given flu vaccines so many times in my career, particularly when I was over the ER in hospitals, and our hospital would give them for days and days and days. And I can always remember each person. Are you allergic to chicken and eggs? No. Are you allergic to chicken and eggs? No. So that hasn't really changed. History of Guillain-Barré syndrome within 6 weeks after a previous influenza vaccine, however, is fairly new. And bone marrow transplant within 6 months. So you have to know that about your patients. Enter 6 if the age condition guidelines is not indicated. So what is that? Well, it's updated all the time by the CDC. You can get those guidelines there, and you have to tell your clinicians that these are the reasons why we would not give a flu shot. So you need to have that before every flu season and in service and give those as handouts. And then only if the CDC declares a shortage. And then response 8, some of the reasons that they put is that the assessing clinician is unable to determine whether the patient received the flu vaccine. Well, obviously you don't want to give a double one. And that's where you would ask your doctor's office. Okay, so this process measures calculated at transfer and discharge with OASIS items. But the receipt of the flu vaccine is at the beginning. So if you're giving the flu shot at the beginning, you need to have documented it, right? Because now you're going to have to see this answer on discharge. The patient's last flu vaccine, and then you put the specific date, but approximate time frame such as fall, winter of 2014 would also provide adequate information when determining if the vaccine was received during the current flu season. You can see that example that I got from CDC was in 14. I should have updated that. When the patient has a medical contraindication to the vaccine, document so that all the clinicians know, so that again, you know how to answer this item. And there is a lot of information on CDC. We have to have an initiative to have all patients vaccinated every year. It's very important. All disciplines should know if the patient has had a flu shot. If they haven't, that's when every discipline can say, are you ready to get your flu shot yet? Because it is important, and then you would document it. You would tell your team then as well, your case manager. And here I put about what I had said at the beginning, that, you know, our patients are homebound and home care is holistic. So, you know, you really should be giving those. And then just the, example of what you have to do when you store them. I've written this up as a deficiency so many times, both on mock surveys and in real surveys, that this is why a lot of agencies say they're not going to mess with it. But you just need to know what you have to do. It's just daily. You have to check the fridge temperature and make sure you have the highs and lows that are needed. And then once you open a vial, you date it for 30 days. When that 30 days is up, that vial gets tossed. And that's the biggest area of deficiency, is that there are open vials that are either not dated or that are way expired. Okay, if the patient or caregiver is not sure they're wanting a flu vaccine this year, have the CDC guidelines and their information readily available for the patient. There's a lot of good information showing that what can happen to elderly folks with comorbidities, particularly when they get the flu. All right, and then you'll want to teach about the safety of that vaccine as well. There are still clinicians that are not taking the vaccine because they don't think it's safe. It cannot give you the flu. It is a dead virus. And so that is a myth, and you can get that data and show that both to your patients and caregivers as well as your staff. And then, of course, refer them to their doc's office if they have concerns. And all your staff should be getting a flu vaccine every year as well. Okay, so 1051 pneumococcal vaccine. Has the patient ever received it? For example, Pneumovax. Simple yes or no now. The item intent, you do it at transfer and discharge, and it's very simple. Response 1 if they had it, response 2 if they never did, or you can't find out if they ever did. Okay, so how in the world can we improve this outcome? Well, you want to give the CDC information on pneumococcal disease, and I have some of that for you, because I know that home care agencies do, for the most part, do not focus on this vaccine. Prior to it becoming an M item with Oasis C1, we pretty much never did it, and still the percent is pretty small. But we are to make sure that the patient does have them. So this information I'm giving you is great for your clinicians as well as your staff and caregivers. You want to ask on start of care. If they think they don't want it, you can bring them more information and talk about it later when they settle down from their admission. You would want to consider reporting to the physician that the patient hasn't had one. And then they can address it on appointments as well. Again, you don't have to provide it. Again, the recommendation is always our patients are homebound, home care is holistic. We're supposed to be preventing worse things. So it also helps you increase this outcome that for some reason is in the value-based purchasing pilot. Again, I have the information on the MedFridge, but be careful with these. Sometimes the pneumococcal are different expiration dates. All right, so some of the CDC information on pneumococcal was really striking to me because I don't know a lot about it. But each year, it kills thousands of adults, including 18,000 adults 65 years or older. Most pneumococcal infections are mild, however, some can be deadly, especially for elderly. And it kills about 1 out of 20 who get it. That is such a high mortality rate. And then the bacteremia, 1 out of 6, and the meningitis, 1 out of 6. And thousands more end up in the hospital because of pneumococcal disease. It can cause severe infections of the lungs, bloodstream, and lining of the brain and spinal cord. So this is where it talks about what it is. It's basically strep pneumonia, and that's what it is vaccinating against. You can see that since it spread from the nose and throat to ears and sinuses, goodness, that's how it's so easily transmittable. And so you can get that mild infection all the time, right? But then if it spreads, that's where it becomes really bad. So, hey, let's keep it from starting. And then, of course, anybody whose immune system is weakened by disease or medicine. It can lead to disabilities like deafness, brain damage, and loss of arm and legs. I think that means movement or feeling in arms and legs. It's spread by direct contact with respiratory secretions. People can carry it and spread it when they're not sick. So, of course, the best way to prevent any of that, get a vaccination. There are two vaccines. It's the PCV13, that protects against 13 strains of pneumococcus bacteria, and PPS V223, that protects against 23 strains. Both vaccines provide protection against illnesses like meningitis and bacteremia, and PCV13 also provides against pneumonia. So I would imagine that would be the one given the most often, even though the other one is 23 strains. They're both safe, but there are some side effects. Most are just at the arm and don't affect daily living. CDC recommends 2 pneumococcal vaccines for all adults 65 and older. You should receive a dose of PCV13 first, followed by a dose of PPSV23 at least 1 year later. I don't know if this is new information to you all, but it certainly is to me. If you've already received any doses of the 23, the dose of the 13 should be given at least 1 year after receipt of the 23. So you see, you have to know which strain. So once the patient tells you yes, then you would have to track to the doctor's office and say, which is it, because we're not sure if the patient needs another one or not. If you have received the PCV13 at a younger age, another dose is not recommended. Okay, so here's where we get into which adults should and shouldn't get the PCV13. Well, it's recommended for anyone 65 or older, 19 or older with certain health conditions, anybody who's had a life-threatening allergic reaction to a dose of the vaccine should never get it. Obviously, they break that out. No, you should not give both of these vaccines, 13 and 23, at the same time. You get, you talk to the healthcare professional to find out when. Can flu and pneumococcal vaccines be given at the same time? Yes. You can get one of the pneumococcal vaccines when you get the flu vaccine. So that's very important that you can go get those, or the home care agency can give those at the same time. But obviously, you don't get the pneumococcal every year. And then it says about the cost that most, Medicare and other insurances cover it. Where pretty much, again, anywhere, and definitely at home care. Okay, so just to close, since this is our ending session, your key areas of focus to improve your scores. And this is the ones that we focus on for value-based purchasing, but it also applies to star ratings, and it applies to every single outcome in your CASPER report. OASIS accuracy and consistency. We went over this in more detail at the beginning, and of course these are 60-minute classes focused on particular outcomes. I could talk for hours on every one of these subjects. They're not something to take lightly and just throw out to you, but I've tried to bring them up in all our sessions. Your OASIS, if you are trying to improve your outcomes before you know that your clinicians are doing OASIS accurately with the correct way to assess a patient and by the intent and guidelines in the OASIS manual, then your outcomes won't improve. If your consistency throughout your clinicians, that every person that does, no matter their discipline, that does an OASIS does it completely different, then you won't increase your outcomes. That is the way to start. You have to make sure that you don't need to give a lot of OASIS education to your clinicians on accuracy and consistency. And I would say to you all, just by my experience of what I see day to day, is that you probably need to give more education. We don't just do mock surveys. We have a lot of RNs, well over 20 of them, who do nothing but review OASIS and do coding every single day. And we still, on clients we've had for years, we can give a full page of recommendations back on that OASIS. So that is something that your OASIS education should be ongoing. A case management model with that interdisciplinary team for every patient that has a caseload together is the way to go. Everybody that has a successful case management team improves their outcomes because the team starts working as a team. They start focusing on improving Mrs. Jones' pain. So it really comes together. Obviously, you have to keep a close eye on your CASPER outcome reports. Check them monthly. Every time they're updated, print them off, the ones that I told you in session 1, and have a detailed analysis of them. And then see what ones maybe you have to add to your QAPI program. Your QAPI program is where all of the outcomes that you're trying to improve should be, because you are doing ongoing monitoring, collection, education, process change. The outcomes that you're focused on to improve in your value-based purchasing, they should all be quality indicators, and they can actually count as your PIPs as well, your performance improvement projects, because now you're documenting that you had education on meds and vaccines today. That can be documented into your QAPI program. If you don't engage all of your staff in your agency, then your outcomes will not improve. Maybe they'll improve, but it'll drop down again, it'll go up, because you really don't have everybody vested and involved. If they're helping by doing the case management team, they're getting the OASIS information ongoing, and they understand how to do it. They're working on QAPI with you. Every clinician should be involved in QAPI in some way or the other over the course of a year. And education, education, education. Remember that all these outcomes, they come right back down to the field staff. And too many agencies and organizations want to start at the top. You can't start at the top. This comes from our field clinicians through the OASIS. It comes from our patients on how our clinicians did. So in order to be one of the successful, thriving, value-based agencies well into the next decade, those are the steps that you can take, and you definitely will see improvement. Now, I told you a lot about HHQI throughout my session, so I wanted to give you the link. If you are not signed up, sign up. There are 17,878 participants and 5,717 agencies. Well, of course, I'm one of those participants, so there are a lot of consultants, and this can affect so many areas of what we do. There's education, some of which I've given you. There's so much more. There are so many best practices that really help you get ideas on how to improve these outcomes and more. Many, many resources. I'll find myself clicking into link after link after link as I'm researching things. It really is focused on improving patient safety and outcomes. It has very much that holistic wellness and prevention focus. So once you get working on those, it's going to help you think more, help your clinicians think more about that aspect of why we're there and how we want the patients to improve. So I think I talked about all the conclusion. Your team has to work together. Focus on several outcomes as a team and plan the episode for care. We're going to improve Mrs. Jones's pain, her medications, and her ambulation. And then the team can really focus on that every visit. There are some that give scripts, give guidelines for each visit on how to improve outcomes. I think that that's a very good idea in this value-based purchasing pilot program. Break education for staff into 1 to 2 outcomes a week, because otherwise it's overwhelming. That's why we did 6 sessions for you. Have task forces with the staff on each outcome to brainstorm. Think outside the box. And then, of course, celebrate when you have increases. Do fun things for your staff, because We really want to focus on improvement of outcomes. Now, I was worried this class would not last an hour, and you can see I have no trouble talking for an hour. It's exactly 12. So now I will turn it over to Patty so that we can see if we got any questions. And I want to thank you all so much for joining HCAS and me and Melinda for these 6 sessions.
All right. Sharon, we do have a couple of questions that have come in, but just a quick reminder for everyone, and we'll allow anyone to type any last-minute questions that they might have. So an evaluation of today's event will pop up on your computer as you go to exit the event. Please make sure you complete the evaluation. And again, if you have more than one person listening in at your location, we encourage them to fill out the paper version that came along with your handouts. And you can send those back to the association you registered with, or you can fax them back to HCAP at 850-222-9251. And moving on to the question, Sharon, first question asks, when it comes to providing patient and caregiver drug education, is it sufficient to document a generic statement that patient caregiver drug education was performed, or should clinicians be more specific with their documentation in each note as to what meds were discussed and education was provided? And do they need to be specific in regards to what education they gave them? So meaning, did they talk about medication side effects or something along those lines?
That's a great question, and definitely it's the latter. If you just put patient caregiver drug education performed, and let me tell you, we see that in many, many, many records. Number one, it will not suffice for surveys because we don't know what you taught. Keep in mind that skilled need, or I should say that medication education is a skilled need for home care. And that means it's a qualifier for us to be having nurses in there to be doing drug education. Now, if you just put that it's been performed as a generic statement, and every clinician then on every visit follows that with those terms, nobody knows what was taught. Nobody knows, reading that legal record, what was taught to that patient specifically to make sure they're okay, number one. Second of all, make sure their outcomes are improving with that medication. So the part after you said the generic, all of the things that you said is exactly what needs to be in the visit notes as well as the OASIS. You have to keep in mind that the team, if the team doesn't work together, now let's say in addition to Bob and Sally, I have Mary, the LPN, that's also working on Mrs. Jones. Well, when Mary goes in, she needs to know if I taught the Lasix or if I taught the oxycodone as a high-risk drug and where I left that, so that your teaching plan flows through the episode of care, and then that has to be very specific. I have seen agencies where, one thing I'm going to tell you, an agency actually got a condition level deficiency for this because there were so many things wrong with meds. But a big part of what they wrote was that everything is generic. You're not even saying what med you're addressing. So really work with your clinicians on that. They can't just take it from the computer-generated statement.
Okay, and along those lines, in regards to medication questions, do they need to provide education and information about every med on every visit, or can they kind of break up the medications over subsequent visits?
Great question. You break it up. Even CMS has finally realized when we went on to OAC1 that if the patient has 20 meds, we cannot teach them all in that start of care visit. My goodness, we have so much to do and the patient's exhausted. So they said you have to teach the high-risk meds. so well, they didn't say you have to. They're asking if you did, but obviously you get the point that you have to teach the high-risk meds. So you're very specific, of course, in your teaching, but in your documentation about which meds you taught. Then, in your assessment, you're reviewing every single med to make your med list and med reconciliation, and you're seeing what side effects there are, what meds are ineffective, what meds they don't have yet. If you see something big come up with those medications, then yes, you would educate on that right away, or you would report that to the physician right away, and so you would document that. Now, on subsequent visits, the nurse that's in there, whether it's me or Mary the LPN, is going to reinforce about the high-risk meds and make sure that the patient is doing well with those, with all the areas we talked about. Then choose a few more of the drugs that make the most sense to pick by the patient's condition, the length of time they were on it, their compliance, their disease process. As an example, I've been on Synthroid, I think, for 20 years now, probably longer. I went on Synthroid when I was fairly young, and my dosage has hardly ever changed. My lab tests are always the same. I don't need to worry about anything with it. Do I? Well, yeah, I do. You're not supposed to take it with some other meds or at certain times. And so if the patient and caregiver already know that because they've been on it for 20 years, then that's the end of the story. You don't have to address that. But you're going to document specifically, oh, I'm on gabapentin. So you're going to want to make sure what my symptoms are, that I'm on, what my disease is, that why I'm on gabapentin, what my side effects are, what the dose is doing for me. Do I still have a lot of problems? Do you need to call the physician? That all occurs during the episode of care. You have to prioritize. You have to be specific. The only way you're going to get through to a patient and caregiver when you're doing heavy-duty med education is to focus on one or two at a time. Now, obviously, you can never ignore anything that comes up with a side effect, an adverse event, ineffective pain meds, etc. But that's how you can do it through the course of your chart. So your team has to talk, right? Because if I don't talk to Mary and Mary doesn't talk to me, now that talking can be through EMR. Even if I'm gonna look at the last visit that Mary did. But is she reporting it to me? Well, she has to. She's an LPN, so yeah. And we have to coordinate our care. So, my goodness, great question.
Okay, and it looks like the final question we have is in regards to the flu vaccine, and they're wondering if you have worked with agencies in Florida who have successfully implemented a flu vaccine program within their agency, and if so, do you have any tidbits you might share for things to consider for agencies that may look to institute such a program in their own agency?
I'm not sure if you mean a program in that you are providing it, you're marketing it, and you're having patients come and you are giving it there or at another location. If that's what you mean, then no, I haven't. But if you mean that they're giving flu shots from their agency to all their patients and their staff, then yes, a lot of our clients, in fact, I can only think of in all the years that I've been doing this, our clients, if they didn't offer them before, we really encourage them to offer them to staff and patients and not to have to refer them out. And so if that's what you mean, you just have to have a blanket generic order, and then you have the medication physician refrigerator, and you have to have the temperature logged daily. You have to know the ranges that you're looking for on the temperature. And then the main things is to make sure that there's no other drugs in there you shouldn't be keeping, and, you know, because as a home care agency you can't, or that